How are you doing today, Deepak?
I'm doing great. I'm very happy to be a part of it. And I'm very sorry that I could not be there personally to join this meeting, exciting meeting in Yemen.
Dr. Deepak.
Hi, Nasir. How are you?
Very fine, sir. How are you?
I'm great. I'm great. I was the only reason I said yes to this meeting was because I knew that one of our best resident from AIMS, Dr. Nasir, will be here. So I'm very, very happy to see you, Nasir. Thank you very much.
Thank you very much,
for
sir.
being
Thank
here.
you very much, sir. We are very happy to be with us here in this conference. And I know
Okay.
Deepak, he is my personal friend and he was my senior and he's excellent in person and excellent in his profession. So please go ahead.
Okay. Is my screen visible to all of you?
Yes, we can see it. Fine.
Okay, perfect. All right. So I've been asked to talk about craniosynostosis. As always, I'll keep my talk very, very simple and very, very basic. I do not know the audience level out here. I believe most of them are neurosurgeons, and some of you do get to see patients of craniosynostosis in your practice to operate. Yeah. So I am presently a professor of neurosurgery and also the chairman of Pediatric Neurosurgery Fellowship Program at All India Institute of Medical Sciences, New Delhi in India. I do not have any disclosures, and because in craniosynostosis, I had to put a lot of pictures of these children. So I do have prior permission from the parents for display of pictures in this presentation. So craniosynostosis is defined basically as abnormal fusion of the sutures or a premature fusion of more than or one cranial suture. Now we must understand, when do we call it abnormal? The easy way to remember is that any sutural fusion, if you see in the first 2 years of life, that is abnormal, because by and large the first suture to fuse is the metopic suture, and it always begins after 2 years of age. So if you see any sutural fusion of any suture in the skull before 2 years of age, then this is taken as abnormal. So in my talk, I'll be basically talking about scaphocephaly and also about fronto-orbital advancements. These are the two things which I'll be covering in my talk. Now, children who present to us with craniosynostosis, they usually have, commonly they come to us with cosmetic disfigurement, abnormal head shapes, abnormal shape of the skull or of the face, or some abnormalities of the fingers and the toes in syndromic variants. They have got a restricted brain growth, and many of these patients, on detailed evaluation, the neuropsychological evaluation and neurodevelopmental assessment, they are often, actually most of them are undiagnosed and missed in the majority. However, if you are diligent enough in examination of these patients and you've got trained professionals, you can actually pick up a lot of neuropsychological abnormalities in these children. Many of these children with syndromic variants, they present to us with headache and loss of vision. In fact, at times in undiagnosed or late presentations in syndromic craniosynostosis, they come to us with loss of vision, which is very sad. As you see out here, there are almost 22 bones of the skull, and there are four major bones which are united by 3 sutures. We have got the frontal bone, bilateral parietal bone, and the large occipital bone. Now, this is the thing which I always teach to all my residents. Please start to learn how to calculate the cephalic index, because this is one of the most commonest morphometric marker used in the clinical practice by surgeons all over the world. So cephalic index is calculated by dividing the maximum cranial width with the maximum anterior-posterior diameter or the cranial length. To put it in the simple word, in a clinical examination, you calculate the distance and about the tip of the pinna at the most widest point. This is the biparietal diameter, and this is the anterior-posterior diameter from the glabella to the most prominent part of the inion at the back of the head. So you take these parameters divided by and multiply by 100. Normal range is 79 to 81. Any cephalic index, if it is less than 75, it favors a diagnosis of scaphocephaly. And if the cephalic index is more than 80, in fact it's above 82, then we call it brachycephaly. Now, scaphocephaly or the sagittal suture fusion is the simplest and the commonest type. It is seen in more than 50% of the cases, I would say. Males have got a very, very high preponderance. Almost 5 times incidence is seen in the males as compared to the females. The classical scaphocephaly is fusion of one suture, that is a sagittal suture, which is a midline suture. Almost 10% of these cases are atypical, wherein you have got fusion of not only the sagittal suture, but also the coronal or the metopic sutures as associated feature. Now, majority of the children, they come to us for cosmesis, that they say that the head is large, oblong, or the boat-shaped head, and they come for a cosmetic surgery to a surgeon. And of course, this cranial deformation can also have major psychological impact on the children. When the children are in the school, their schoolmates may complain and may say that, oh, you are born with some abnormal head and all that, and they commonly bring it to the notice of their parents, which often comes to their attention, and they come to us for evaluation and further treatment. Abnormal high intracranial pressure is not uncommon in scaphocephaly, especially in the atypical variants. And 10% of these cases of sagittal sutural fusion, they have got coexistent intracranial pathologies. Role of preservation of surgery in preservation of cognitive skills is not relevant in majority of the cases, I would say. This is how the atypical scaphocephaly actually look like. In the interest of time, I will run over it. Now, you talk about the neuroimaging. There have been a lot of controversies and debates and on what investigation to do to avoid CT scan in these patients because of ALARA guidelines. But by and large, majority of the surgeons in most part of the world, they do end up getting the high resolution or the three-dimensional NCCT head of these children, of course, in the low dose protocol. So you can have the plain X-ray of the skull wherein you can pick up this sutural fusion, and the CT gives you a lot of information in these patients. I always get NCCT with 3D reconstruction of all my children, and along with that, I always do MRI of the brain and with MR venogram, because it tells me lots of additional information, the presence and absence of hydrocephalus, the herniation or the presence of Chiari, because in case a patient of craniosynostosis has got a Chiari malformation, this makes me change my plan completely. I have to do more of a occipital distraction or a posterior fossa enlargement in these cases rather than approaching this patient from the front. So, and of course, the MR venogram tells us about the abnormal veins and the bone cuts which I have to make, and to prevent any inadvertent sinus injury or the venous lakes injury in these patients. So it remains, I would say the CT scan remains unquestionable because it gives a lot of diagnostic information, and additional intracranial pathologies are actually picked up on CT scan in these children. Now, these are the abnormalities you can see in these patients of scaphocephaly. You can have frontal bossing, bitemporal depression, pinching, prominent sagittal ledge, occipital bossing. And this presentation, I can share it with you and your residents can see it later. So I will skip it in the interest of time. And so these are the twin cases. Both of these children were born on the same day by cesarean section. They came from south of India to me, and it was a parent's request because the kids are born on the same day. We want them to be operated on the same day. So it was a big challenge for me because an average surgery takes to me almost 4 to 6 hours per patient. Anyhow, and they had a rare blood group that is AB negative. So I took up these challenges, and one of the child had got classical scaphocephaly, and other child had got atypical scaphocephaly, wherein the coronal suture was also fused. So these are the CT scan of these children. You can see in one child, not only the sagittal suture is fused, but also the coronal suture is also fused. However, if you look at this child, the sutures are patent. You can see the coronal suture is patent, and the back cut, the lambdoid suture is also patent. Only the sagittal suture from the front to back is completely fused. So this was classical scaphocephaly, and the second child was atypical scaphocephaly. So this is the beauty of nature. You can see both the variants in the twins together. So this is what I did. I did cranial vault remodeling and advancement in both these children, and they were 1 year of age when they were operated. In fact, a week after the surgery was their birthday. And the intracranial pressure, interestingly, was high in one of the child of 22, that is atypical scaphocephaly patient. So these are the bone cuts, and we have to do a lot of play around with the bones to give them the correct shape at the end of the surgery. I'll just quickly show you a video of these children. And so this is how the child was looking like before the SPECT was suggestive of hypoperfusion. And this is the pericranium flap being raised and the bony cuts being marked in this patient. And then I do intracranial pressure monitoring in my patient to see what is the pressure before opening the skull. And you can see the pressure was on the higher side, 24 in this child. Subsequently, the bony cuts are made as per your preoperative planning. And now the skull, the bones are out, and then outside you can reshape the bones with the shape you have decided before the surgery for the children.
So I made multiple barrel step incisions both in the front and all around the bone, and this is the original shape. So by this, now you can
give green stick fracture and expand the frontal bone to your liking to fit in the best shape to this children.
Looks much better now. See?
And this is the midline sagittal ridge which was removed.
I would like to break it.
And this is how the child looks like before and after the surgery. And both the childs look exactly like each other. After the surgery, the parents were pretty happy after the surgery. You can see the large head before and the nice head shape after the surgery. All right. So basically, I would say that in scephocephaly, one needs to distinguish between sticky sutures and the sutural fusion, which can be easily done based on the CT scan or the X-ray imaging. Atypical scephos, they require tailored treatment and the follow-ups. The cephalic index is something which is recommended for all patients, should be done as a baseline. And the preoperative 3D CT with recon with surface rendering is very, very useful. And I often feed in these images in my obstetrics, and I plan out the surgical procedure beforehand. And earlier the better. I most often operate these patients at the age of more than 6 months of age. And of course, most of these children, they require prolonged follow-up. The second thing I want to cover in my brief talk is about the forehead advancement, because we must understand all these patients of especially the plagiocephalus and the syndromic variants, they require some kind of a forehead and a frontoorbital advancement. So this advancement basically consists of two parts. The inferior part is the supraorbital rim. This is the supraorbital rim, and the superior part is the frontoorbital forehead up to the coronal suture. And if you talk about the supraorbital rim, this is also called as bandeau by some surgeons, and it consists of supraorbital rim and part of the orbital roof and the lateral orbital wall. So this whole construct is called as a frontoorbital bandeau. So when we say, we always do frontoorbital advancement and reshaping of the anterior 2/3 of the skull ahead or just behind the coronal suture. But for doing this, absolute knowledge of 3D plane is very, very important to the surgeon, because the basic concept in the deformity correction of this patient is you have to do deformity correction in 3 planes: anterior, posterior, superior, inferior, and side to side. And you can see out here before the surgery, I usually make my 3D STL models of these children, and I plan out before the surgery what are the cuts I have to give in the frontoorbital bandeau to give a nice shape, because at the end, whatever the shape you will give to this frontoorbital bandeau, the same shape will be taken by the forehead and by the growing head of the child. So these are the level of cuts, and this is the advancement I have done in the side-to-side plane and in the front projection. You can see I've given a lot of space in the front. So by giving this space, the unrestricted growth of the brain, which is maximum in the first 2 years of life, is allowed to the patient and giving a good outcome to these patients, apart from the cosmetic outcome itself. You can see this child with a grossly deformed plagiocephaly. You can see before the surgery and after the surgery, a nice contour of the head is being given to the child. This is another child, 18 months old child, came to me from Dubai, and you can see this child had a nice contour. And if I do a 3-month post-operative CT for my children, and you can see there's a nice space I've created, and almost 1.5 centimeter advancement I've done in the lateral, and almost 1 centimeter advancement I've done in the frontal projection also to this child. And this child now has got a 1.5 year follow-up, and he's doing absolutely fine. This is another child, and you can see I do the planning, I do marking of my cuts, where exactly the frontal eminence I want before the surgery, by doing my photometry and Photoshop before the surgery, and I decide what is the shape I'm going to give to my child at the end of the surgery. So I superimpose the patient's clinical image and the soft tissue image, and I do photomorphing, and I do my photo cuts planning before the surgery. What are the level of cuts in the frontoorbital bandeau I have to give the right shape to the surgery. So I go to the theater with a preoperative planning, and you can see this child with a very severe brachycephaly. The head is almost flat, in fact sunken inside, with a marked craniosynostosis. And this is how the child looks like 2 months post-operatively, and it's a very decent outcome we have got on this child. So these are a couple of other cases. And sometimes we have to rotate the 180 degrees rotation of the entire forehead, front back, to fit in the contour after doing the advancement of the frontoorbital pentule. So knowing this thing is very, very important for most of the surgeons for giving a good outcome. This is another child you can see with a metopic craniosynostosis. I had to do a frontoorbital advancement and reshaping of the frontal pentule. So what is the best time to do? There have been many publications from the Necker group in the Paris and from other parts of the world. It has been seen the incidence of raised intracranial pressure is high after 1 year of age, and in syndromic variants. You can see out here in brachycephaly and complex craniosynostosis, the incidence of raised intracranial pressure is up to the tune of 30 to 47%. And of course, the better mental outcome is also noted in children of Epert's if you do surgery less than 1 year of age. So my personal recommendation is the best time to operate these children is after 6 months of age. They become fit for anesthesia, the bones become pliable, they can be molded, and the child tolerates the surgical procedure well, and there is no added damage to the child by delaying the surgery further. So for me, the best time I would say is 6 to 12 months of age. If any child comes to me before 6 months of age, I prefer to do just plain suturectomy, either by the open procedure or by the endoscopic procedure. But then you have to add it on with some helmet therapy to these children. But if the child comes to you after 6 months of age, which is the setting in most of the patients coming to me in my country in India, so therein I usually do a frontoorbital advancement with anterior 2/3 cranial vault remodeling in most of my cases. This is another video of a child wherein a child was 18 months of age and who had bilateral coronal and sagittal craniosynostosis. And you can see this child before the surgery. And then you can see out here, I do my marking intraoperatively where exactly I have to do my frontal eminence on right side, left side. So I take out this mid part of the frontal bone to bring it together, and of course this height needs to be restored.
I'll try to keep a margin of approximately 3.5. So this is 3.5 from.
So this is called as a geometric or a mathematical correction of craniosynostosis. You can see all these cuts which we are making is after thorough preoperative planning in these children. So it involves a lot of mathematics and surgical skills if you are really aiming for a good cosmetic outcome to your children. So the bones are being elevated under vision, and of course you need to avoid hypothermia and blood loss in these children. And you can see this is the bone being reshaped, and we can put it these absorbable plates either on the inside or the outside, and this is how the planning is done. And this is the advancement being done. You can see these absorbable plates being used, and see the head looks pretty decent, I would say, no? Yeah. And this is how the child looks like after the surgery. So most of the patients of syndromic and some of the patients of non-syndromic, especially plagio, trago, oxycephaly, they need a frontoorbital advancement. And these are the few syndromic variants of Epert's, marked Cruzen. In fact, this girl came to me at the age of 15 years, and I did just a frontoorbital advancement and some amount of CVR in this patient, and now she's waiting for mid-face distraction for taking care of the process further. This is another child with significant Epert's, and we operate. This is another girl with Epert's, and this is another girl with the Cruzen syndrome. This is a child with the Cis-Jordan syndrome, which we operated recently. And these are the collection of patients which I have done. And there is a lot of controversy regarding the supraorbital supratrochlear nerve. However, I would say that in children less than 1 year of age, you can safely get away by damaging. I don't say that you should not make an attempt to save it. You should attempt to save it. However, if in patients when there is an atypical transaction of supraorbital or supratrochlear nerve, it is usually fully compensated in these children. The most important thing I would say is that I've started avoiding putting any Fishhook retractor in these children, because these children have got narrow airbase. The tube size usually goes is around 2.5, 3 or 3.5. And when the anesthetist, when you do some amount of flexion with this Fishhook retractor, the tube can get kinked further, leading to rise in the EtCO2 in these patients, and patients can have intraoperative bradycardia and in fact cardiac arrest also with excessive neck flexion in these children. So you should keep a strong watch on the PCO2 maintain the temperature of these children, avoid significant blood loss, keep a watch on the sponge count in these children, because these are the things which are very, very important, and you learn from your mistakes. We do on an average 10 to 15 cases of craniosynostosis at all Institute of Medical Sciences. The most common complication, I would say, is the blood loss and the hypothermia, which one needs to avoid. And of course, there are a lot of training modules. I do my training of my residents and my fellows on 3D STL model. You can make these models. This is a polygalactin PG and PLA models which can be made before the surgery, and you can practice and to keep minimum. And of course, the cosmetic and the functional results are better with the early surgery and surgery in infants as compared to surgery in the older children, I would say. I would like to thank my nursing staff, my teachers, Professor Mahapatra, who is my mentor, and of course my patients and the parents who showed confidence in me to give their children in my hands to operate. I just want to bring it to notice of all the surgeons who are listening to me that at All India Institute of Medical Sciences, we have started 1-year Pediatric Neurosurgery Fellowship course, and it's a course for 1 year. The seats are open in the month of February and August. The web link is www.aims.edu, and anybody can apply for this course, or they can write directly to me at my email ID, drddeepakgupta@gmail.com, for undergoing fellowship in pediatric neurosurgery training at our institutes. We do almost, I would say, 1,000 children per year out of 5,000 operations that we do at our institute. And I also take this opportunity to invite surgeons to AIMS Neurotrauma Conference. We will have a AO Neuro course also just prior. This will be between 26th to 29th of October at All India Institute of Medical Sciences, New Delhi, India. Thank you very much.
Thank you very much, Deepak. I'm sure the Yemeni neurosurgical community really appreciates you taking time from your vacation to give such a great presentation. Okay, we have a couple of minutes for questions. Ishmael,
7 minutes.
you want to run that, please?
Do you have any questions? Okay, one question. There is one question, Dr. Deepak. Stay with us.
Yes,
a very simple question. Do you think that the age plays a role? I mean, do you have any age limit for the procedure performance? The maximum age?
Yeah, so in patients with pure scephocephaly, which is very, very common, you should do suturectomy as early as possible. I would say suturectomy endoscopic procedures have the best results if done before 4 to 5 months of age. This is about the non-syndromic variants. However, if you're talking about the syndromic variants, my personal take is the best age to operate these children is at the age of 9 months of age. People recommend after 6 months, but after 9 months, so between 9 to 12 months is the best time to operate the syndromic variants. But if you just want to do plain suturectomy, the best age is before 6 months of age.
Okay, thank you. Thank you.
Okay, thank you very much, Dr. Deepak, sir.
And Nasir, you should come to India. You have not come to India ever since you left us. Which was the year you were with us in 2006?
I'm coming frequently to India. Almost every 3 months I have come 2-3 times to meet you there in All India Institute of Medical Science, but I couldn't meet you, unfortunately.
Oh my God.
But hopefully I'll meet.
Okay.
Thank you very much, sir.
Thank you very much. And Nasir, I'm very happy to see you. If there are any other questions from the panel, I'll be very happy to take.
Okay, thank you very much, sir.
Okay, Victor, do you have any questions? Or Mauro? Or
congratulations, Dr. Deepak. Your kind of surgeries is really amazing. I hope to see you next year in Nueva Delhi. Greetings from Mexico City.
Welcome. Thank you.
Thank you.
Gracias.
You have any more questions?
No more questions.
Okay, Deepak, thank you. Thank you very much.
Thank you very much, John.